I have the pleasure of introducing our speakers this morning. I'm really excited to hear their talk and learn from what they have done in the maternal mortality review team. This morning, we're going to have Dr. Adams and Dr. Zapata speaking on those topics. Dr. Adams is an assistant professor of maternal fetal medicine here at the University of Wisconsin. She received her bachelor's of science and doctor of medicine degrees from Marshall University. She completed residency in obstetrics and gynecology at Summa Health System, Northeast Ohio Medical University. She moved to Madison for her fellowship in MFM and also a master's in clinical investigation program through the University of Wisconsin here as well for clinical and translational research. She is a graduate of the Mixed Methods Research Training Program through Johns Hopkins University. Dr. Adams is passionate about improving care for all pregnant patients through clinical research and quality improvement. Her primary area of focus is pregnant patients affected by substance use disorders, particularly opiate use. At the local level, she has been the founder of the Fresh Beginnings Baby Shower, which introduces patients to caregivers in the hospital and helps to empower and reduce stigma. At the state level, she is the Wisconsin American College of Obstetrics and Gynecologists co-chair for the Wisconsin Maternal Mortality Review Team. In this role, she leads a multidisciplinary team to increase awareness of the issues surrounding pregnancy-associated deaths and make recommendations to promote change among individuals, communities, and health systems. Dr. Zapata also has a very extensive CV. I am going to do my best to pick out a couple of the highlights here. She is a graduate of Marquette University for her undergraduate work and received her doctorate of medicine here at the University of Wisconsin. She performed her pediatric residency here as well. In addition to that, she completed a master's in public health and also a residency in preventative medicine and public health. She has extensive work at many levels here in the community, in the hospital, and state and nationwide. She is the chief medical officer and state epidemiologist for community health. In that role, she has a lot of duties. She provides medical and public health consultation and leadership for multiple bureau programs. And she serves as the state epidemiologist for maternal and child health and chronic disease prevention, leading surveillance and research activities for the purpose of public health planning. She has an extensive list of other activities, publications, and also is very active in the community. She has many media appearances, including on the Today Show that caught my eye. And I just want to welcome these two amazing speakers to our forum this morning. And we're all really excited to learn from you guys.
All right, good morning. How are you all feeling this morning? Thumbs up, thumbs sideways, all right. Well, thank you for that wonderful introduction and thank you for this invitation to come speak. This will be different than regular grand rounds. It's more of a conversation. So who's excited to have a conversation today about how we can decrease, oh, I see India raising her hand high, about how we can decrease maternal mortality in Wisconsin. So I'm gonna let Jackie say something.
Good morning. I said this before, but we got a few more people in the room now. Just as a fair warning, about halfway through, we're going to stop talking and make you guys talk. So cluster up. Maybe we've got a middle group, a side group, and another side group here, maybe some smaller groups. But our goal is really just to present to you our new data and then have you guide us on what we can do next in the MMRT. So for today, congratulations, you're all officially our honorary MMRT members, and we're going to have a meeting and talk about our next steps.
All right, so a little bit of a background. Jackie and I have the honor of serving as co-chairs for the Wisconsin Maternal Mortality Review Team. And what that is it is a team that comes together to review all the deaths of pregnant people in Wisconsin who died either during pregnancy or within 1 year of pregnancy. So every single one of those deaths, our team at a statewide level investigates. We look at hospital records, we look at police records. There's even family interviews that take place that we're able to review. And we look at all of the situations surrounding that death, and we come up with a few key determinations. Was that death pregnancy related? Was that death preventable? What were some of the contributing factors? And most importantly, if that death was preventable, we as a team come up with recommendations on if these recommendations are implemented, how could that save a life? So we come up with recommendations that could potentially save future lives. The team is composed of experts who represent organizations involved in all aspects of pregnancy care, and we strive to include representation from multiple disciplines. And as we go through our data today, we're going to just give a couple highlights from some of the recommendations from one of our recent reports that came out. But the big picture question we want you to keep in mind is, how can you create a more diverse team to reduce maternal mortality in Wisconsin? Who else do we need to bring to the table? What perspectives do we need to bring to the table? What more can we do? What other actions can we take? We currently on our maternal mortality review team, we have public health, perinatal nursing, midwifery, psychiatry, obstetrics, doula, social work. We even just brought on a police officer as well. And that's just giving a little example of what we've been doing to try to add diversity to the team and different perspectives. But we want you to think about, in whatever areas of influence you have, how you can do the same thing.
So just to give a quick summary, can you guys hear me okay? Just so we don't have to keep moving back and forth. Okay. Just to give a quick summary, this is from our very recently released 2020 data. Just in case you haven't looked at MMRT data before, it's always a couple years behind. That way we have aggregate data over the last few years. Also, as you can imagine, our abstractors, it takes time. It takes time to get those police reports, those hospital records, those outside hospital records, and prenatal care. So that's why our reviews are always going to come out a little bit after the year of the person who is unfortunately deceased. So there was about a 30% increase in pregnancy associated deaths from 2019 to 2020, with a total of 49 in the year 2020. Of those, 43% were found to be pregnancy related. 38% of all 2020 pregnancy-related deaths were due to mental health conditions, including overdose. And 29% of 2020 deaths were due to cardiovascular conditions or hypertensive disorders. So this is a trend we're continuing to see. Wisconsin really mimics the rest of the United States, and that overdose has actually surpassed hemorrhage and hypertension and cardiac disease as the #1 killer of pregnant and postpartum patients. And we're only continuing to see this trend change. Obviously, we'll look into as COVID numbers affect this as well. But for 2020, this is the trend that we've continued to see.
And as far as mental health conditions, they include the following disorders: anxiety, depressive, bipolar, psychotic, substance use, and other psychiatric conditions. 38% of pregnancy-related deaths, again, due to mental health conditions. And 88% of the pregnancy-related deaths that we reviewed were due to overdose. 10,543 birthing people had a mental health or substance use diagnosis at the time of delivery in 2020. And so we're really seeing that those are driving our numbers. As far as recommendations, we'll go through these briefly. We won't read it word for word, but you can see it. Recommendations for providers: really referring patients with mental health conditions to wraparound services is something that we found incredibly important. Again, remember, when our team is making these recommendations, it's based on actual facts from the cases that we're reviewing of individuals who died, where we saw that if this contributing factor would have been improved, this person might still be here. So wraparound services, improving that, and care coordination can be something that saves lives. Again, as we're going through these recommendations, think about what you're doing now to implement these recommendations, but who else do we need to bring to the table? How can we create more diverse teams to do this? Providers should complete screening for substance use for all patients and be provided with assistance and support in treatment of addiction. And then providers should use Periscope or telehealth consultations. Who's used that before or needed it or heard of it? Awesome. When patients present with mental health concerns.
So just in reviewing these two, I think it's important to think about every time we have a meeting, whenever we're going through our recommendations, we're constantly asking the group, okay, we've got a bunch of recommendations for providers. What else do we need for the community? What else do we need for facilities? Um, one thing we talk about a lot is we have very few individual level recommendations. And that's always a topic of discussion because we really want to make sure that we're not putting the impetus on the individual patient to advocate for themselves. We want to make sure that the impetus is on their provider and the hospital system and the health insurance companies. So when you're looking at these, also think about that too, that it's not just what you're recommending, it's who needs to do that, right? We need a who, we need a when, and we need a how. So when it comes to facilities, some of the things that we talked about, facilities should develop strategies to actively engage patients in need of treatment, provide opportunities for treatment, and implement mechanisms for follow-up. I would say follow-up for patients that don't show up for appointments or that leave against medical advice, things like that, is one of the most common things we see in MMRT. And it's really interesting because the documentation just sort of ends. This person maybe had a catastrophic life event or an overdose event or a mental health event, and then the record just kind of stops on where their follow-up was. And so that's one of the things we talk about a lot is how do we make sure all the right players are involved to get the person the follow-up that they need. Facilities should assign social workers to patients who are at high risk and have a history of trauma to help them in navigating care systems. Help in navigating care is another theme that we see a lot. You'll even see notes from family interviews and things saying that the patient was really, sort of away from their family. They weren't engaging in care. They weren't engaging in treatment, or the person may have had issues with language proficiency or something like that and making follow-up appointments. So how do we make sure that those people that need our help the most are getting it? And then primary and obstetric care clinics should implement integrated behavioral health whenever possible, and hopefully within 24 hours of identified mental health concerns. We always talk about screening, but the most important thing about screening is you have to have a brief intervention to follow, right? And so making sure that we can all screen everyone for mental health and substance use disorders, but there has to be a system in place so that we can follow up on those needs.
Yes, thank you. And as far as top recommendations for systems, health systems need to invest more in education for their healthcare providers in understanding substance use disorder and helping to decrease stigma and judgment. Oh, raise your hand if you've seen it. In being honest, patients coming in with substance use disorder that have worries about stigma, or you've seen it with your own eyes, stigma and different treatment. And sometimes we have to face the ugly truths that are here in our healthcare system before we can actually change them. So just recognizing that is important. Health systems should incorporate prenatal care coordination providers, community health workers, and others with the ability to establish strong, trusted relationships with patients. We're seeing a lot of distrust with the healthcare system, and rightfully so. Healthcare systems should explore alternative models of prenatal care for people with complex social situations, substance use disorder, and mental health disorder. And then as far as recommendations for communities, communities should connect patients with inadequate social support to resources such as support groups and social services. That was a big one. Social isolation was definitely a contributing factor to many of the deaths that we saw related to mental health conditions. Again, as we're going through these, start thinking about who else do we need to bring to the table? How can we create diverse teams to be able to implement some of these recommendations? Schools should provide curriculum addressing violence prevention alongside other counseling classes and health classes throughout childhood. And communities should amplify public health campaigns for friends and family to recognize signs of suicide, ideation, and how to connect with mental health emergency services.
So the other major cause of pregnancy-related deaths that we noted in 2020 was cardiovascular conditions and hypertensive disorders. I think as OBGYNs, this is what we classically think of, right? These are the things that keep us up at night, our hypertension, hemorrhage, heart disease. And what we really saw in our review is that about 29% of all pregnancy-related deaths in 2020 were due to cardiovascular conditions or hypertensive disorders. Other related outcomes, about 48 people experienced severe cardiac complications during their delivery, and about 7,113 people had a hypertensive disorder during pregnancy or at delivery in 2020. And I think we see this play out, right, as our population has more chronic medical conditions, has pre-existing hypertension, that leads to heart disease, right? And then we also have younger folks that have had heart surgery before that are now growing up, adult congenital patients. So it makes sense that we're continuing to see this trend. As far as cardiovascular conditions, some of the recommendations that we had for providers, providers should educate patients with chronic heart disease and obesity about warning signs and symptoms of heart disease and pulmonary embolism, such as chest pain, and when to call 911 and when to present to the emergency room. I think this is really important too. We need to make sure that the patients understand their discharge instructions. And that not only are we doing this counseling when they're in the hospital, but they actually have things to refer to when they go home. I actually just read a really interesting paper out of Tennessee where they did a chart review, and out of their major hospital system, less than of all of the patients that needed an interpreter, less than 15% of them went home with any sort of discharge instructions or medication follow-up in their preferred language. And when we think about that, how we can go over it, but patients are tired. Maybe they've had an adverse outcome. They don't remember all these things that we tell them. So we talk a lot about this too. How can we make sure that we're not only saying it's great, you have to tell the patient when to follow up, but we have to give them the resources to do so. And then healthcare providers should continue to stress the importance of managing chronic conditions before pregnancy. I think this is, we keep saying recurring themes, but it's once you get on this, it's true. It's like you just watch the train about to run into the station over and over and over again. But a lot of patients with chronic medical conditions like type 1 diabetes or heart disease or chronic hypertension or other things just really we're seeing a lack of sort of education prenatally and then after pregnancy about follow-up and certainly before becoming pregnant. And so I think it's really important that we stress that to any patient of childbearing age.
And having a focus on cardiovascular conditions and hypertensive disorder recommendations is also important because that is the #1 cause of Black maternal mortality in Wisconsin, pregnancy related. And so this whole talk isn't about combating inequities, but this is a big inequity that we have in Wisconsin. And so the cardiovascular conditions is what's driving that particular one. Other recommendations for facilities, hospitals should have systemic processes in place for acute and aggressive management of severe hypertension during pregnancy. And facilities should use things like the Hear Her campaign materials to educate providers and patients. And then health systems should pay for and incorporate nurse home visits as part of postpartum follow-up programs. So those are just a couple things to follow up on. And so now as we're getting ready to transition into our conversation that we want to have with you all, we want to acknowledge members of our current MMRT for their dedication to this critical work. And they are listed here. I see some of them shout out in the audience that we have. We have Dr. India, who has just gave some great contributions. And then we also have Beverly, who helped invite us to speak today. Thank you so much. And while we're talking about this piece, before we ask you to engage in a conversation with us about things that you all can be doing to bring more people to the table, we wanted to just pause and talk a little bit briefly about work we've been doing as co-chairs to work to add diversity to our team of perspectives, even changing the way we present our cases to make it more accommodating. So right now we have about 60% of members of the maternal mortality review team at the statewide level, 60% are clinical, have a clinical background, and 40% have a non-clinical background. Several years ago, it was almost 100% had clinical background. There were mostly just like doctors and nurses who were coming together to make these recommendations, review the cases. But over the years, there's been a big push to recognize that we need to bring more people to the table other than just people who work in the hospitals and clinics to add diverse perspectives. Over the last few years, we've also been doing a big intentional recruitment to bring doulas on. So that has been a wonderful perspective to have. I'll let you talk about some of the other
Yeah.
background.
And so we really noticed a need to get different perspectives. So some of the things that we did to try and actively engage in this is our last recruitment was actually our first targeted recruitment. So we were specifically looking for folks of a First Nations background, rural representation. So many of our cases come from rural communities. And that's really been a game changer because we're like, why didn't they just call this person or do this? And they're like, hi, I'm the only OB provider within 2.5 hours of where my patient lives. Who am I going to call? And so we really wanted to make sure that we included rural voices as well. And we're actually, Dr. Zapata's impact team is going to be working on a rural health brief because we've had such a need and such a request for that so that we can put out recommendations on how to help with rural care, which, you know, we're all about here in this residency. And so you guys are part of the solution. Another thing that we really needed was representation from law enforcement. And so we actually have our first law enforcement representation on the group, which we're really excited about. He's already been so crucial in reviewing a case about domestic violence and sort of the background of that. And it's been really eye-opening to have him on the team and just to hear his perspective and his history. And, you know, it's really easy for us to review a case that ends tragically and look at all these flaws, but then to hear from him, well, you guys don't understand the 20 things that were probably happening in the background. So, and now our next goal is hopefully we review a lot of cases of loss of custody and how that relates to maternal mortality. I'm sure you guys have all heard me anybody that's talked to me for more than 15 minutes has heard me on my soapbox about this. So we're now trying to get a little bit more background on that. We're actually hoping our next recruit will be someone from Child Protective Services so that we can have that background as well. I'll let you talk a little bit more.
Yeah, and as you can imagine, when you start to bring people from different backgrounds and different experiences, you have to really focus on making sure that everyone feels welcome and comfortable. There's I don't know if I'm allowed to say this, but somebody referred to the maternal mortality review program a few years ago as the good old boys club. Like it was only just like a certain population of doctors who sat around and talked in all this medical language, and the solutions were coming from just that narrowed perspective. And if we're going to make a significant impact, we have to bring different people to the table and make them feel comfortable. So we've had ups and downs. We had a lot of ups, but we've had low spots where when we brought in, especially bringing people that don't have a clinical background, especially with lived experiences, come onto the team, there was very broadly, I'm speaking, but situations where two doctors would be discussing a patient, but there were other members who were non-clinical feeling like it was very impersonal. Like, how can you even call this a case? We call it a case. What do you mean? That's an actual living person that's been impacted. And in fact, my aunt or my relative went through the same thing. So we really had to pause and make sure that we were working to accommodate everyone. So definitely growing pains, and we're still making improvements. And so one way that some things that we're doing to work on that, one change that we did over the last, like the last 6 months to, 6 months, at the beginning of every presentation where we present the individual who died, the very first slide has to be only positive things about that person. We really dig through their social history, even if it's to say, this was a 26-year-old white woman who was in school for culinary school, was a mother, a wife, and loved to dance. And then we'll just pause to just give a moment for them to have their humanity, to just bring out their humanity, to remind ourselves this was an individual who had things that they liked and enjoyed. Pause, and then we'll go into going through all the data, going through the case. So even very small changes like that, we have gotten positive feedback, and it seemed to be helpful. We also have community building events, so everybody will get to know each other and interact and build relationships. We also, sometimes you have to bring in outside reinforcements as well. We had the opportunity to work with the Black Mamas Matter Alliance, which is a national organization who does amazing work in this area. They actually came into our maternal mortality review program, and they partnered with us to seek community feedback on how can we be more transparent, how can we bring out the humanity in the patients that we're reviewing their cases. And they also helped push us to make sure that the representation on our maternal mortality team was, it was proportionate representation to the communities that we serve regarding race and ethnicity. And I'll let you talk about that a little bit.
Yeah, so right now our breakdown, we're really working on increasing diversity in our representation. Like we said, well, I think we said 60-40. It's about 52-48 clinical to non-clinical. Our rural representation, we have 5 members from rural areas, 30 from urban. And then we're also working on just increasing our general diversity. So as of right now, we have members, about 17 of our members identify as white, 3 as Asian, 9 as Black, and 1 as American Indian. And our goal is to eventually really mimic the demographics of Wisconsin and make sure that we just continue to increase our diversity on the team. So when we talk about diversity, we're talking about diverse teams. We're not just talking about specialties represented interests. We really want to make sure that we're being person-centered and that our team represents the people that we serve. So
In 26 counties.
yes,
represented.
26 counties. That was my favorite fact when we did this review. I was like kind of blown away by that actually. So
Mhm.
well, with that, we've kind of told you all the things that we're working on, things that we're trying to do better, things that we think are going great, and we're always continuing to improve. But now it's your turn. So at the end of the 2020 report, we introduced the 7 key questions to reduce maternal mortality. And this isn't just key questions that we're asking ourselves or our organizations, it's things that we're hoping that we can talk about and have a group discussion about. So what do you think? Should we just do one group, or should we split up smaller than that?
Maybe the 2 to 3 people you're sitting closest
Yeah,
to.
there we go. Let's break down even smaller. And so grab a couple people. We're gonna have a conversation. And we're basically gonna talk about these questions, talk about our 2020 data, and then we're gonna ask our groups to report out basically as long as we have time. So the rest of the time is up to you guys. Creating pandemonium.
Right. All right. So this is going to be a rapid fire conversation with your groups. Everyone say rapid fire. Did you guys hear me back there say rapid fire? Rapid fire. So you have about 90 seconds to discuss this question, all right? After reviewing this report, what are some of the data trends that stood out to you? And we're starting our timer, and you have 90 seconds to talk about question 1 with your group. Thank you.
Feel free to put that in the chat because I'm afraid I'll mess all this up. So at the end, I'll just make sure that it's the chat.
Yes. He just got done presenting about maternal mortality in Wisconsin and what things these amazing OB/GYN providers can do to decrease maternal mortality in Wisconsin. I have my co-chair here with me. We are hot off the press. We just did it. And now we have amazing doctors and researchers having small group conversations about 7 key questions to reduce maternal mortality in Wisconsin.
We're shaking up Grand Round.
Yes, shaking up Grand Round. This isn't your normal Grand Round. Well, that was great. Okay, there's my timer. Okay, maybe I'll let them go 2 minutes since this is the first question. We'll go faster for some of it.
I think that's good because we're right on track.
We're
too.
good, yeah. We didn't really leave time for them to ask us questions, but maybe we can say, we'll stick around after you
Yeah.
guys have questions for us, but this is great. 30 more seconds to wrap up this rapid fire question. Oh, I feel like, yeah. No, you're doing great. Well, because you're an actual OB, you're like, yeah, we see with our patients. I'm like, I don't know what you guys are doing over there with the mom. I have no clue. I'm like, just give me the baby. All right. All right, let's come back together. Let's come back together. Even just one question we could talk about for hours and hours, but this is just getting the conversation started, okay? Can each group just, not each group, but somebody from this section, the middle section, and this section, maybe just say one thing that stood out to you, something you discussed in your group. Can we get a volunteer from this area? What was one data trend that stood out to you? Mm. Thank you. Thank you. What about this group? Someone from the middle section. Can anyone volunteer to share?
So it makes sense that that number would be lower. Like that's a success on our part,
Mhm.
but we're not so vigilant about mental health disorders and substance use disorders. And so, you know, these numbers reflect where we spend our time and energy. So they make sense.
A good one. I like thinking of that, framing that as a win. Framing it as a win of why the hypertensive disorders is not the number one. And what about this section? You guys were having some good conversation over here. Well, give us a sneak peek of what you said. One volunteer, please. Okay.
We talked about the mental health disorder piece a lot, and just how overwhelming and discouraging it is as individual providers when we feel like we can screen and get a positive screen, and then finding the wraparound care is difficult. So we're talking about, do we have enough social workers? Are we paying social workers enough? Where are the services? Where are the therapists where we can refer our patients to? So at least to me, that feels like the most kind of overwhelming and discouraging piece is just what we're lacking in terms of like a systems.
Thank you. Thank you. And everyone say action. Action. I'm gonna let everyone knows I like talking about the data, but like I really love focusing on action. We love focusing on action. So I'm gonna let Jackie read this next question and you'll get another 90 seconds.
Yeah. And don't worry, some of these are more complex. We'll give you more time. We'll kind of see how the discussion goes. And we basically were like, we're just going to go until people are tired of talking. So, mental health condition were the leading cause of pregnancy-related death in 2020. In what ways have you seen this in your own community or organization? And what are some tangible steps you can take to help promote optimal mental health for birthing people in Wisconsin? So, you know, it's we talk about this a lot in our team too. Sometimes we have to take 5 minutes because everyone's overwhelmed and we're all sad. And we just have to really step back and say, okay, we've talked enough. What actionable things can we do? And pie, really, like, what can we do right now, all the way to pie in the sky? What would we like this state to look like in 5 years? So, right now, we really want you to focus on things you can do in your own practice, in your own community, for the residents every day in triage. When you're feeling beat down and you feel like you don't have the resources, what are some steps you can take? So, we'll give you a little bit of time and then we'll report back.
All right, we're gonna come back together. All right, great conversation. And remember, this is just the beginning of the conversation. We want you to continue these conversations at lunch, when you're hanging out on the weekends, when you're at the holiday barbecues. We want you to continue these conversations. So this is just the beginning. So let's start on this side this time. Can you guys give us one highlight from your conversation? What are some of the tangible steps you can take to promote optimal mental health for birthing people in Wisconsin?
One of the things we're actually working on is embedding behavioral health and easy consultation to psychiatry services in our obstetrics clinics. So Ryan McDonald is heading this up, and he and I are meeting with Ned Kalin and the behavioral health teams. It's in the UW health system, right? So we're talking about statewide, but you know, we're a very well-resourced system. So we definitely need to work in that way. And then Beverly brought up something really important, and that is something you guys have emphasized, is the sort of that team concept. So it's not a psychologist or a psychiatrist, it's social workers and healthcare educators and providers across the OB spectrum. But trying to really connect behavioral health with our patient population that we serve is the first step. It's an action step.
Thank you so much. Awesome. We love taking action. One thing I wanted to say, it reminded me of something Beverly mentioned to us in a meeting we had yesterday regarding this topic. And it was so striking, but I wanted to just bring it out again. It was something to the degree of, it takes on average 17 years. That's what I looked up to, 17 years for research to be translated into clinical practice. 17 years. And so I'm just so excited that even the fact that we're doing this today, that we're having these conversations, let's not take 17 years to put some of these recommendations into action. So thank you. Thank you. Thank you. All right. I see a hand. Awesome.
yeah.
A hand.
Thank you for your presentation. Two things we were talking about were language and screening. So when like the saying like mental health like deaths related to mental health conditions, like in my brain, I divide that into two categories of being like potentially substance use related accidental overdose versus suicide or intentional overdose, some other means of death in the setting of like a psychiatric illness. And like, I think being able for us to delineate those things helps when it comes to screening, because there's different tools than we use to screen for these different conditions, right? Because we were talking about triage, you know, like that's not a place we typically use to screen for these things because we're focused on this acute, whatever complaint they're coming in for. And I know like we have validated screenings, we have particular times like when some establishes for prenatal care and things like that, where we do these screenings, but maybe being able to take a step back. And if is there a more generalized way we can screen at more intervals, like for these two things, like looking at suicidality, looking at potential for substance use disorder? Just thoughts we were having.
No, and you bring up a great point. There's actually a lot of talk about this because this is unfortunately one of the downsides of the way that maternal deaths and deaths from mental health and substance use and overdose are reported, that a lot of us are really unsatisfied with, is because they do get lumped together. I actually tried to do a meta-analysis a couple years ago on overdose and prevention, and it was virtually impossible because every single paper I pulled had suicide mixed in with it. And we spend a lot of time talking about this. Every single life that we review in our team, one of the questions we ask was this suicide? Was this homicide? You know, those are like some of the basic questions we go. Sometimes it's not clear, particularly with overdose, but you're totally right about screening. Even when you screen and your visit matters. There was a really nice study out of Boston that said if you do it at the beginning on an iPad, nobody's going to actually answer it, and you'll get completely different answers than you do at the end of the visit once you have a rapport built with the patient. So I wish we had all the right answers, but you know, and screening at more intervals certainly is important too, because somebody might not feel comfortable at the beginning of their pregnancy, but then by the time they are in triage and crisis or something like that can happen. So great points. These are all actionable steps too. Like we need more screening, and we need it to be with a provider that the person trusts and knows, and we need to make sure that it happens like when we have the availability of a brief intervention to offer them too. So.
And then this section.
So I'm pretty passionate about rural healthcare and low resource areas, and I've done a lot of rotations there. And I think one thing is just asking people when they're not in a mental health crisis, who are your support people that you can actually reach out to? so they can identify those people because they don't think about it until they're in a crisis and then they can't name those people. So I think even taking like that small step during like a clinic appointment or a check-in appointment of can you name somebody who you can reach out to who's a trusted individual is super important.
That's definitely important, bringing in others. Who else, and that's our question, who else can we bring to the table? So that's amazing. Thank you. So we're gonna just do one more rapid fire question and I'll let Jackie read it.
Great. So after reviewing this report, which community-based organizations or systems can you commit to developing or strengthening a relationship with in order to implement some of the key recommendations? We really wanted to focus on this, especially for our trainees. Who can you include in the conversation? Instead of just listening to clinical voices, think about family members, community health workers, get on the phone with a doula or a family member. Is that something you've ever thought about? These are just some of the things that we toss around a lot in the MMRT, and we're hoping to hear from you guys.
90 seconds. Not admit.
I'm sorry that you have to come in.
It's okay. I get excited when we get to do stuff like this.
This is great. I've never heard people talk about it.
It's like everybody's so focused. Yeah. Yeah. Raising awareness is so important. Okay, it's 8:08. All right, we're gonna wrap up. Wrap up. All right, I see you all are excited to partner with outside organizations and systems. But let's start with this middle section. If you just share one thing of what you talked about. Yes, right there.
Our group talked about the benefits of talking to other people that might present with a patient, kind of how you were saying, like either getting on the phone with or talking to someone in the room who might be a trusted person. We've had experiences where like either partners are in the room. I've had experiences where people like postpartum come to the ED with their doula, and it can just provide some helpful context, especially if the patient present is like either very anxious or unable to kind of fully give context on whatever's going on.
Oh, thank you. That is so important. How about this side?
the patient might feel comfortable confiding in if they don't feel comfortable confiding in the medical providers. So like noting who a person's doula is and how to contact them and just having that relationship with them can be really helpful.
Yeah, that's so important. There was some research actually that I did. I won't go into all the details, but basically asking Black birthing people in Dane County what would improve your relationship with the healthcare system. And one of the themes that we're seeing from our qualitative research is that they wish that their healthcare providers would be more accepting of and have better relationship with their doulas. So what you're saying is so important, and that's what many patients are asking. Thank you.
Yeah, patients in recovery too, peer
Yeah.
recovery coaches, community health workers. It's not just doulas. It's everybody that's there to support the patient is on your team too. So
And what last one with this section?
We discussed for people who are looking for community organizations to recognize that the name of the organization may not be salient to the services that they provide. And I know in science and medicine, we can be very matchy-matchy, like it doesn't say prenatal, it doesn't say obstetrics and so forth, therefore, and it might not provide these services, but really understanding that trust will supersede and override your skill set every time. So it doesn't matter how trained someone is, if you're screening them and they don't trust you, they're not going to be honest. So the question that was asked in the back, which is who do they trust? That's key. And it might not seem like that person can provide whatever you think they should be providing, but if you can get to truth, you can potentially get to treatment. And so understanding how important trust is foundational, and understanding outside of different cultures, outside of different socioeconomic backgrounds, what trust looks like to you might not be what trust looks like to the patient population you're serving. And so how do you get to trust? You just can't. I know we spend a lot of time in our trainings, but you can't in that one-to-one, one-to-two conversation underestimate the value of getting to trust.
Awesome. Trust. If you can't get the trust, you can't get to the treatment.
I'd like to
That's-
make a comment on that if I could.
Oh, please. Who is that? Speaking. Oh my goodness.
Uh, Yeah, that's the night doctor.
yes, Dr.
Luther Gaston.
Gaston.
Yeah, trust is very key. I actually have to trust the people that I refer people to. Uh, and I had a patient, he's for one of our residents because I trust that resident. And I know that what's in their heart. Now, when I get up beyond our residency, that's when the problem comes. I haven't been to my primary care appointment because I'm trying to look for a different one. But there's nobody that I trust in Madison right now. So I may have to go to Chicago. I may have to go to Milwaukee. I may go to Washington, D.C. But if I think I'm in a system of, and I mean, because of white doctors in my best interest, go there. And I had a young man, black, big dead now, was evaluated for screening, and he was a UW worker. And all of a sudden, he went from, "Oh, you don't have anything, you shouldn't be doing prostate screening on you," to, and so I trust in the doctors here.
You were cutting out just a little bit, but I think the biggest theme you were saying was the importance of trust. Okay. All right. Well, this is exciting because we are going to continue the conversation. I'm going to just read a couple of the other 7 key questions so you can reflect on them. I want to highlight that in the report that just came out, these 7 key questions are there. So I encourage you to get that. We know racism can play a role in pregnancy-related deaths. In what ways have you seen this in your own community? What are tangible steps you can take to combat this? After reviewing the recommendations, what are the top 2 that are feasible for your organization to implement in the next 90 days, what are feasible for your organization to implement in the next year. What barriers do you anticipate encountering as you work to accomplish action steps? And what strategies will you use to overcome them? And the one I love to end with is, what are areas of promise or hope you see happening in your organization? And we actually talked about a couple of those today in the conversations. What's working well and that you can support or bring more awareness to? So I'll let Jackie say our final closing, and we'll stick around after this officially dismisses to answer any one-on-one questions you have.
We just want to thank everybody for participating. We hope it wasn't too much of a shock that we made you show up and work this morning, but what we love so much about the MMRT is all the different people that we get to work with, all the different perspectives that we get. And we, Dr. Zapata and I really believe that conversation is where change happens. It's not just sitting around reviewing numbers. We all know I love numbers, but it's really when we sit down and we work as teams. And that's what we're really hoping that we implore upon you today, is it's not all on you. It's not all on your hospital. It's not on the insurance companies. It's on every single one of us. So thank you. And thanks for being good participants.